if you could take a minute, Dr. Landgren, first, and talk about the phase 2 study for the DARA antibody for imaging. Like, where is that going to be open, and how many sites will be open when you open the phase 2? I'm kind of curious about that. And then I have a couple follow-up questions before we start Q&A.
All right, so thank you very much for kind words, Jenny. Well, so the phase 2 study will open at the University of Miami at Sylvester Cancer Center. And it will also open out in California at the Hoag Cancer Center, because my long-term friend from the imaging department at Sloan Kettering was recruited to lead the molecular imaging program out there. His name is Gary Ulaner. So Gary and I wrote a large grant, which was funded from the NIH, and that gave us the funding to do the first 60 patients. Mm-hmm. We also are planning to expand the work. So for now, it's going to be Miami and Southern California.
Okay, that's awesome. And what you do, the genetics is so confusing. I mean, like, I look at that and I go, how do you do precision medicine with 10,000 mutations? Like, how's that even possible?
My thinking is that myeloma, similar to most cancers that I'm aware of, is a highly heterogeneous disease. Mm-hmm. I think most patients at a new diagnosis have several thousand mutations. There are some mutations, if you look across the board, if you have 1,000 patients, for example, which are the common mutations you see? So there are actually two mutations that are relatively common. One is called NRAS, the other one is KRAS mutations. They are about 20-25% each. So they make up half the patients would have either N or KRAS. But if you start drilling deeper into the data, you see that not every cell in a patient who has an N or KRAS mutation, not every myeloma cell will have that. Mm-hmm. And if you start drilling deeper and deeper, what you see is that there are subpopulations of myeloma in every patient. So I think in a simple way, you could think of it as every patient with myeloma have many myelomas going on at the same time. Mm-hmm. And when we treat, what happens probably is that the disease goes, for the most part, away. But if there is a relapse later, the cells that come back may have a different skewing towards some of the subsets. So that could be one dominant type of cells in the beginning. When the disease comes back, for the most part, seems to be another subset coming back. And then when we treat again, it goes away. And next time, another subset comes back. So I think a key question in my mind is to try to treat with the best drugs upfront, do these imaging modalities that we are trying to develop, and take out those cells and see what they actually look like, and see if we can get rid of them. And if there is a common theme across many patients, we will start using those drugs upfront together with all the other drugs we already have. Mm-hmm. But if there is more of a variance, that's have to be dealt with differently. So I think the precision medicine is different from a disease where you already know there's one target or there are three targets. And if you figure out if it's target 1, 2, 3, you target that with certain drug. Myeloma is very...
And Dr. Hillengass, would you mind taking just a minute to talk about the study that you're also doing? And then we'll jump into Q&A because we have a lot of questions.
It's actually a pretty similar approach. We just try to do it while the patient is still awake. I didn't know how to put that better. Dr. Landgren does the analysis, but of course, in more patients with an easier access, we of course are limited where we can do our biopsies. But it's very interesting. We found things that we did not even look for when we compared those osteolytic lesions with the random sample, and I can only echo everything Dr. Landgren just said. We see, unfortunately, that myeloma is multiple myeloma. That's something that I stole from you, Ola. It's just not only one disease. It is different within one patient. It is different between different patients. So it's still, unfortunately, a lot to do. I think we get closer. I don't know, and maybe that's something we can discuss. I'm not sure if we really are there that we can treat really targeted, because we know we will target a certain set of cells. But I absolutely like the idea, and that's also what we try to do. We do biopsies after treatment, as you know, to look for MRD. If MRD is positive, we look for the genetic changes there, and then we might have to change our treatment. We might have to adjust the treatment because those cells have already survived our, I don't know, upfront treatment, whatever it is. And then we have to adjust. And I completely agree. The best shot we have on myeloma is at first diagnosis. But on the other hand, so that people who are already in relapse are not too depressed after this talk, I think we still also have a lot of options in relapse, and the new developments will always be first tested in relapse. So the first is our best shot, but later on we still have options and we can still adjust our treatment according to the patient's biology of the disease. So it's very exciting what we learn, and we hope that we will learn it fast so that as many patients as possible can benefit from those results.
Yeah, we hope you learn it fast too, because who doesn't want to like have these newer techniques and better imaging? And yeah, it's unbelievable. Also, I want to mention that you are also doing a study inside of HealthTree. Do you just want to mention that for 30 seconds?
Yeah, so with HealthTree, we looked, and HealthTree is amazing. We asked a question about the physical activity, and there was actually a question also about that, the physical activity of myeloma patients, and it's so impressive how much patients suffering from this disease still do. So that's very impressive, and we want to learn if we know that physical activity, workout, cardio, strength training has an influence on the immune system. We think that it also has an influence on the bones. Of course, we have to be very careful with fragile bones in myeloma patients, but we think that doing nothing is definitely worse than doing something. And my experience is that a lot of patients do something without knowing, and oftentimes without the approval of their physician, because of course we always have the fear that something bad happens. But what we want to learn in a safe environment of smoldering myeloma patients, we want to see if increasing the physical activity has a benefit for those smoldering myeloma patients, because we know their bones are not affected yet, at least not in the macroscopic level. So we hope that we can improve the immune system of smoldering myeloma patients, and we would like to roll that out through HealthTree, where we will ask patients and will send them blood tubes so that they can draw the blood, and then we get the information about the immune system, and we do that before and after those prompts that we want to do. We will give out these Fitbit devices, and it's not a commercial for Fitbit, it's just the device that we use. And you can get text messages through that and say, okay, do XYZ number of steps today, do XYZ number of steps tomorrow. And we want to see if we can program a fitness program or develop a fitness program for myeloma patients. We start with smoldering just because we cannot supervise those patients, but this is a goal that we have, and we are at the moment applying for funding for this.
Mm-hmm. Okay, awesome. Well, we look forward to helping and support that. So we have questions. I have questions by email and also in the Q&A. So I'm going to jump back and forth between that. And Dr. Hillengass, you may have already answered this first question from Ivy. She just is asking, how effective is the CT PET scan with or without, and the both of you can answer, by the way, with or without contrast in determining plasma cell changes in the bone marrow for a smoldering myeloma, lambda free light chain type with no M protein. So I know you cannot both answer questions that are specific to a patient, so just speak broadly about the topic if you would. We know that somebody would have to have a consult with you to answer a particular question, and actually with telemedicine, that's probably pretty easy to do, so they can probably make an appointment with you, right?
Yeah. That would work, yeah.
Mm-hmm.
So briefly, the benefit of PET-CT is that we have the combination of the PET information, which gives us information about the metabolism, how active those cells are, because the PET tracers and the old PET tracers, and I'm very excited about Dr. Landgren's work with the CD38 directed tracers, which are much better, but we are not there yet. So in general, the tracers that we use right now use sugar that is attached to a nucleotide and a radioactive tracer, and that goes into the cells that need the most sugar, and myeloma cells need a lot of sugar, any cancer cell does. And so the PET-CT shows us the metabolism, and since it is PET plus CT, the CT part shows us the osteolytic lesions. Why would we still use MRI? MRI is very sensitive to changes, especially diffusely low level in the bone marrow. We see those changes earlier than with the regular PET-CT that we have now that might change together with the CD38 antibody tracers. But PET-CT gives metabolism. MRI has a higher sensitivity. That's the reason why I usually use MRI in the early stages, because we want to be very sensitive. When we know there's already a myeloma, the PET-CT is better because we can say a lesion is still active or is not active anymore. There's a very small subset, about 9 to 10% of patients who have a certain change in their myeloma cells called a hexokinase that they are lacking there. And this hexokinase is important to take up this tracer and to show the tracer in imaging. So a very small number of patients will be negative in PET-CT, even though there's active myeloma. That would also be a reason to use MRI. And another question that I answered in the chat is that the diffusion-weighted imaging shows us, just briefly for everyone, shows us cellularity, meaning if there are many cells, like for example in a myeloma focal lesion, or if there are less cells. Many cells have a lot of so-called lipophilic cell membranes where the cells have kind of a fatty cover, and the water molecules cannot move that far in a very high cellular tissue. If the tissue has a low cellularity, those molecules can move further, and the MRI machine can differentiate it with a certain setting. So that was a long answer to a short question, but I think I try to kind of give you the framework of those techniques.
Mm-hmm. Dr. Landgren, do you have any comments as well?
No, I think Jens covered it, as always, very, very well. I have really no additional details to add. Maybe just re-emphasize the fact that the current imaging modalities we use when it comes to molecular imaging with current PET-CT is glucose-based. So the assumption really with current PET-CT is that there's a consumption of glucose that's higher in the malignant cells. In myeloma patients, obviously the myeloma cells. But the assumption is not myeloma specific, it's across the board. So it was developed years ago, and it works very well in certain diseases like lymphoma, because those cells have very high consumption. They are very highly proliferative. Mm-hmm. But diseases like myeloma, the assumption is going to not be fully accurate because the glucose is very high in many patients. And I had on one of my slides indicating that about 30% of patients that do actually have a bone lesion with myeloma, they are negative for PET. So I think there is a lot of need to develop new technologies.
Yeah, I totally agree. Those differences we're really studying.
Maybe I should actually came up with a new thought here. So what I showed was CD38, but obviously there's a whole range of other targets as well. And we actually have developed in the lab for mice other antibodies. So we have not taken them yet into humans, but I think a potential future avenue could be to have many different antibodies could be given in a similar way as flow cytometry is developed to try to characterize potential residual disease. So I think there's a lot of development to be done, but to me it looks extremely promising.
Yeah, I totally agree. Okay, Mindy has a question a similar question Paul had, and I'll give a little background on her, but just take the general too. So had her first PET scan in 2007, second in March of 2020, which she had to get 10 low-dose radiation treatments. Another PET in June, new hotspots, new radiation treatments, started a new treatment in July. Specialists noted the myeloma clones not going well, not behaving well, and recommended another PET in this month, but the radiologist is delaying. So when you have these differences in opinion between an oncologist and a radiologist, like, what do you do as a patient and when do you push for the scan when your insurance company is pushing back, right? And you can both keep your microphone on during this time if you want for Q&A.
I do. So I think at my institution, in order to avoid this from happening, we have day one, this work together. We have to have one voice. So we have our radiologists attending our conferences every week. It's a small group of radiologists that see the patients. So last year at Sloan Kettering, we had over 10,000 outpatient visits for myeloma. That's a lot of visits. But there are very few radiologists that look at our pictures. So that makes them very good at it, because they look at myeloma all the time. And also we have a very close relationship. So the faculty talks to the same doctors all the time. If I have any questions, I would call them and they would answer me right away. So I think going to a place where there is that communication, I think that's important for the patient. It's very confusing and it's very disruptive to get different messages. It doesn't really work. And then, of course, some are difficult questions. There is no clear answer. So I had a case last week. I felt I could, of course, come up with a solution, but I felt it was the right thing for me to bring it up to the faculty. So I asked the whole faculty, what would you do here? I asked the patient, do you want me to address it? He said yes. So I brought it up at the tumor board. We had a discussion. I called the patient right away and said, we had this discussion, and this is what actually everyone said. I didn't tell them what I thought. I asked them first, and everyone said, this is what we want. And that happened to be the same as I thought, but I wanted to hit first. So I think doctors have to also work together internally. I don't know, Jens, what do you think?
That's exactly what I would have recommended. We also have a weekly tumor board. We don't have 10,000 patients per year, but we still have a decent number. And we have, and this tumor board sitting in one room, or now sitting in one Zoom, is that it gives this close personal relationship. And the radiologists, they ask me, I ask them, we exchange, they learn from me, I learn from them. And the relationship is not that I have to prove them something or that I have to overrule them or anything. Sometimes I question them and then they tell me, hey, this is what I see and this is what I think. And then I say, okay, I accept or not. I mean, I think the hematologist should bring everything together. We are the ones who make the treatment recommendations, and our radiologists really, they appreciate that. They say, hey, I don't know what next treatment would be the right thing because that's your expertise, but this is what I see and this is what I think you should do. And I appreciate their expertise, and that's what they do all day long. So I don't claim that I know it better than they do, even though I do imaging for quite some time and have done 1 year of radiology, which is not a lot, and definitely not not outweighs their expertise. So I can only echo collaboration is very important. Of course, as a patient, you're kind of in the situation that you cannot force your doctors to collaborate. But again, what you said, Jenny, I think it's important to at least every once in a while, or at least at first diagnosis, see a specialist. And I think in most centers that I talk to, where there's really a dedicated myeloma group, the connection with radiology, almost everyone knows that this is very important. And so they have their tumor boards as we do, and they are very helpful. And then it's not I say, you say, it's we say, and we together make this decision and make this recommendation.
Okay, great. Okay, Todd has a question. Oh, no, go ahead. Go ahead, Dr. Landgren.
From Jens and I, but I was just thinking, we do the same at our two institutions, but maybe for a patient who goes to a smaller place, maybe there is no tumor board. I think the answer to that patient is that could be a good reason to seek a second opinion at the larger center. And if the patient came to us and said, I have been given this advice and it's different from what these other doctors have told me, what would you do? What we would do is to say, can we please have access to the images? We will upload it. We will generate a formal read, and we usually within 24 hours. So our radiologists upload it. They have the system, they get it, and the radiologists will read. They will write the report as if the images were done at our institution. I would get the report, and then I would do the same. And I'm sure Jens has the same setup at his place.
Yep. And now is like a prime time to just do a telehealth visit.
Right.
So yeah, it's like, let's take advantage of it while we can. It's awesome. You don't have to fly anywhere. So perfect. Okay, so Todd had a question. He's kind of more in the newer diagnosed category, but very knowledgeable still. And he mentioned that Dr. Hillengass, you said that with sometimes treatment, focal lesions can disappear. I think it's a really common question for patients. Do my lesions go away? Do they heal? So yeah.
Yeah.
That's a
so there
question.
are yeah, we have started to look into that in a multi-center study back in Germany, in Heidelberg. Unfortunately, we never came to publish it. What we have seen and what we see in clinic, I just 2 weeks ago, I had a patient who had palpable lesions on his skull, and he got treatment, and we did the PET-CT before and after. And I looked twice because I didn't believe, but I couldn't find some of those smaller focal lesions anymore, the osteolytic lesions. The focal lesions, the bone marrow focal lesions, oftentimes disappear. The osteolytic lesions, as you know, when we are older, when we fracture a bone, it takes longer to heal than, for example, Ola's young son. He will fall, he will break his arm, and a few weeks later, everything is like before. That's not happening to us anymore. So if our bones grow slower, I think a combination of a good proteasome inhibitor that we use nowadays, and where we know that they help to rebuild bone, a bisphosphonate or a rank ligand inhibitor like denosumab, in combination that, and then bring the patient in a deep remission, then there's the chance, there's a good chance that those lesions heal. We don't know, some patients, even they are in a deep remission for a long time, still have osteolytic lesions. We don't know if the time was not long enough, if there are other factors that are influencing that, we just don't know it yet. We try to analyze that, but this is maybe something we could work together on, Ola, with your large patient numbers, because it's really with a CT, with the more sensitive techniques, we see bone healing, maybe not a complete disappearance of the osteolytic lesion, but we see that lesions shrink, or at least at the rim of the osteolytic lesion, there is bone regrowth. Again, we don't know what the factors are yet, but I think it's a very interesting field to see how can we take care of those lesions, because now we can keep patients alive for quite some time. Now we want to keep them alive very well. And I think that maybe exercise might help with that.
Yay, we think so too. Okay, and Dr. Landgren, I think this question would be a great one for you from Paula. How are myeloma specialists using the results of PET-CT scans or any other imaging along with MRD? And I know you addressed it a little bit, but I think expanding on that as we look at myeloma more holistically, you know, is you're looking at a lot of different factors. Are you relapsing, and how fast is the relapse, and what's the bone damage look like, and are you MRD negative? So yeah.
If I understand the question, how do experts in the field for myeloma handle imaging in parallel with MRD testing? That's the question. Mm-hmm. So the current landscape for MRD testing, if you look at what's FDA approved, FDA, there's really only one test. That's the adaptive bio test. There is similar technology called in vivo scribe, so VDJ sequencing, that set up at certain institutions that is very similar. It's not yet clear, but it could still be institutional and state cleared for clinical utility. So both these two technologies are bone marrow based. Now imaging covers, if you do a whole body, covers the whole body. So if you put it and the bone marrow is negative for MRD, and then the PET-CT shows, unfortunately, there could be some area lighting up. As we have discussed here today, that could be interpreted as sampling error. So if I saw there was an area that lit up, I would look at the CT. I would discuss with my imaging colleagues. This is an example of how this collaborative team effort we just mentioned kind of would work at my institution. We would ask them, is there anything we need to do additionally? If they say do a dedicated MRI to characterize it, or they would say it looks suspicious, we would discuss with the patient, and we may do or offer the patient to do image-guided biopsy. So if we show now that there is a residual site, that could have implications. The patient could potentially be offered to do focal radiotherapy. But it could also be that we biopsy this and there's really nothing. This happened to me many times. And then we say, good news, is negative. But we cannot completely rule out that it is really true. There is unfortunately always the possibility of false negative. So maybe we would repeat imaging again after 3 months to make sure that it really is negative. And many times you can see that there are processes in the body, inflammation, infection, or even like little trauma. Someone bumps into something and it lights up. There is more recovery. There are immune cells recovering the tissue, and they eat glucose, and that lights up and tells us that there is something there. And we don't know if it's immune cells or myeloma cells. So a repeat imaging would then help us. So that's kind of in a nutshell how I would do it. I don't know what Jens, if you have other ways of handling it.
Yeah, no, exactly what you said. We also do the imaging after to make sure that we didn't miss anything. Sometimes we did. We did just recently, I had a patient where we did a guided biopsy of a lesion that was still there. It was PET negative. It was MRI positive, coming back to this differentiation. And we did a biopsy and we did MRD out of the osteolytic lesion and it was negative. So that was really good news. Patient was happy. I was happy. Again, we will still do another imaging in a year to make sure that we don't miss anything. So I think that is a great idea, and that's what we do. And we also look it up in our tumor board, because if there is any discrepancy, we want to know why, we want to learn why. But I'm intrigued. I thought a lot about, if there's still myeloma left, should we change the treatment? Should we go on with treatment? We do maintenance treatment, so we go on with treatment. But if you had a residual PET avid lesion, do a biopsy, it's myeloma. Would you do, if it's 20, I guess you will not do radiation, but if it's 1 or maybe 2, would you do radiation or not? I thought about that a lot. I have not encountered that, but would that be something? You as well as I want to cure myeloma. That's our goal. That's why we get up in the morning, but not only, but a lot of it. Would you radiate or not? Because radiation also has side effects. So yeah, what would you do?
So the question is, if a patient was treated and MRD negative, you did imaging and you found one site.
Yep.
So
I haven't. I have to admit I haven't done it, but I think it is worth a thought.
So what we would do is that we would do image-guided biopsy. And if we find it there and everything else is gone, we would have a group discussion. And every case is different, but I can tell you we have had situations where the consensus was that, but the way it's always discussed back to the individual patient would be that this is what we have found. We have discussed this. There is no written document or book saying that this is right, this is wrong. It's unknown. But our judgment, based on many years of experience, we have a large program. We believe that this would be a reasonable approach. And then we would say the benefits from this could be this, but the risk could be that. And then if there's an alternative approach, we would give the patient the option. So I think one option would be to do some alternative combination therapy. And another option would be to do targeted radiotherapy. I guess another option would be to do nothing and say that you could monitor it. And I think you have to be always honest, obviously. You and I are very much right. I think there are questions when the doctor knows the answer, and the doctor has to say, we don't know what the right answer is. Or recommendation would be this, and this is why. So that's how I would handle it. I think it's the same, right?
Yeah.
And some of these questions relate to a question by Katie, who was diagnosed with myeloma 7.5 years ago. So IgG lambda, no high-risk genetics, planned transplant, increasing numbers, but lots of bone issues. So she's had a PET CT every 4 months, she's had 11 PET CTs. And when you start thinking about like the radiation plus the radioactive, they put you in the room with the radioactive sign on the door, and you just kind of, okay, so here I am, contrast versus no contrast. I don't know. Is there another way to monitor bone metabolism or activity with safer tests? I guess you were working on one of those, or with blood tests. And then with patients with low M proteins that might not qualify for studies, but lots of bone damage, are there clinical trials, she's wondering, that she could join? She wants to join a CAR T trial, but her numbers are too low.
Yeah. Maybe to the amount of radiation. Yeah. Every 4 months, that's really a lot over 7 years, you said. So that's a really long period of time, a lot of radiation. I mean, you always have to find a balance between what information do you really need as a treating physician. Of course, the imaging will help to prevent her from, hopefully will help to prevent her from further fractures. So that it is important, but on the other hand, at one point, the radiation also has side effects. In the long run, it can cause secondary cancers. It's very difficult to say that in her specific case, if there are no changes within 4 months, I would next time do it after 8 months, for example. With these hypo-oligosecretory myelomas, it's always a challenge. I try to do more of this diffusion-weighted imaging, which doesn't show us the bone that well, but it shows us the infiltration of the bone. So when I have several oligosecretory patients where I do MRIs every 6 months, which has no radiation exposure. And then if there's something suspicious, if anything is growing, then I do a PET to confirm and a CT to confirm. So that's how I try to avoid too much radiation exposure. With the clinical trials and also struggling with that, especially further advanced patients oftentimes lose this monoclonal protein and have more changes in other areas caused by the myeloma with very low light chains, very low M protein. The companies who sponsor the studies oftentimes require that the patient has at least 0.5 grams per deciliter M protein or at least more than 100 free light chains, and a lot of patients in the later stages don't have that. I'm not sure, Ola, do you have a study open where you can enroll patients with this low secretory disease, especially CAR T cells? Because I just had to send a patient. Actually, I was asking Sham if you have a study where you can enroll oligosecretory patients. Some studies allow that, some don't. It's just a decision of the company that is sponsoring the study.
If we do have open CAR T cells for patients with oligosecretory or non-secretory, the answer is yes. The current study that we have opened for that category of patients is a study that's based on our internal discovery work for GPRC5D, which is one of the newer targets. As you know, everyone has developed all the commercially available CAR T cells against BCMA. So the one I mentioned, GPRC5D, we published Science Translational Medicine from Eric Smith's work in our group. And show that even if we turned off BCMA with CRISPR screens, we could still kill the myeloma cells preclinically when we went after GPRC5D. So we have a lot of confidence in that. Because we developed this internally, we could say that if we take images and we see the disease and we treat and we take images, or we do biopsies and we see the disease and we treat and we do biopsies after and disease is gone, that would be justified to do so, and we could document that in our protocol. The problem against is the drug companies, their trials, they will send the data to the FDA. The FDA have rules, obviously, to determine responses. So if you cannot prove that the monoclonal proteins or light chains go down, then you don't have the official proof that the therapy delivers. So it really comes back to the fact that the companies need to develop and get the drugs approved, and the CAR T cells need to go forward. But for an academic study, you could do for other purposes. And also, once the drugs are FDA approved, when T cells will be FDA approved, clinicians like you and I could use approved CAR T cells for patients that are oligosecretory or non-secretory, obviously. Yeah. So for now, that's what we have.
Okay. We have a lot of questions, and what I'm going to ask you to both do, I'm going to keep going for another 5 minutes or so with questions. And then when I'm showing people HealthTree, I'm wondering if the two of you can answer some of the questions in the Q&A. So we try to answer them all, but we don't get to everybody. Harold has a question. What scans required contrast, which is good, and what are the current guidelines for patients with kidney issues?
Yeah, that's an excellent question, and I answered one of those really good questions in the chat. So all the MRI images that I showed you were without contrast. There are very rare occasions where you really need MRI contrast in myeloma patients. There was a study that a patient mentioned, very good catch. There was an ASH abstract showing that gadolinium, which is the basis of the MRI contrast, stimulates myeloma cell growth. But that was only cells and only in animals. And we have done a study with several hundred patients where we compared patients who got contrast versus patients who did not. And the only difference was there was no difference in survival, no difference in progression-free survival, no difference in kidney function. The only thing was patients who had a significant kidney failure or kidney dysfunction before did not improve their kidney function. So that was the only finding where the gadolinium contrast agent that is used for MRI was significant. For CT, we try to avoid as much as possible. If a patient has a heart attack and needs a heart catheter, then they need their contrast agent. It's important, and they can get more fluids and their kidney function will be monitored. But usually also for CT, for the bone is very dense. You don't need contrast agent for the bone. So if there's not a really, really good reason to use contrast agents, it should be rather avoided. The level of kidney function, usually in MRI, we recommend that more than 1.5 milligrams per deciliter for creatinine should not get contrast, a gadolinium contrast, because there's a long-term side effect that looks like sclerodermia, which is a really horrible thing that you don't want. So bad kidney function should not get gadolinium-based contrast. Another thing that patients ask me when they read a lot, gadolinium can accumulate in a certain area of the brain. There is no data whatsoever. We used it for, I think, over 10 years now. There's no data whatsoever that it has any influence on the brain function. So there's no data for that, to my knowledge at least. So contrast agent avoid if possible. To summarize, gadolinium not over 1.5 creatinine, and CT or X-ray contrast as little as possible. If possible, avoid it completely. And for myeloma, you usually very, very rarely need it.
Mm-hmm. Okay, and another question is, Dr. Landgren, is the DARA, tracer that you're working on, would it work for light chain amyloidosis as well?
So we have never tried in patients with amyloidosis, but I would think so, because the light chain amyloidosis is a disease of light chain restricted plasma cells, and CD38 is very highly expressed on the surface of these cells. Another line of evidence, if you want, that it very likely will work is the fact that daratumumab is very efficient treatment for patients with light chain amyloidosis. So I would think yes. We have just not gotten to that yet. We just did the first in-human patient study for myeloma, so I guess we need to expand.
We're jumping ahead on you. Yeah. Okay. I'm going to ask one more question, and then. Yeah, I know. We want the future today. I don't know. We're impatient patients, as you both are as well. Impatient in seeing what you can accomplish and what's possible. So it's super exciting in my opinion. But Bonnie's asking what imaging. I think patients
are running against the clock.
Yeah, I know. We feel like we're playing beat the clock all the time, and so do you. So Bonnie's asking what imaging is just best for monitoring patients in remission to capture early relapse, and why. And some of the questions were like, if one cell is causing all this relapse, how do I pick it up as early as possible? And then, maybe if I'm on treatment, when should I do that? How often is normal?
There is no scientific data to say what would be the best. My personal experience, and I would like to hear what Dr. Landgren has to say. My personal experience is we do a PET-CT once a year in our treated, for example, patient after a transplant or a patient in remission. We do a PET-CT once a year. We have found a few patients where there were only changes in PET-CT before there were changes in any markers like immune fixation negative, PET positive. So that's very sensitive. In patients that are in remission longer, which we hope, I switch after 1 or 2 years, I switch to MRI because of the radiation exposure. So that would be my recommendation. Start with yearly PET-CTs and then go to MRIs. And if MRI is positive, then you need another PET-CT to confirm. That's usually what we do. And one thing, if the insurance company causes trouble, sometimes what we also can say, and that's also based on some of the work you have done, Ola, is that you can have second primary tumors, other cancers that can develop caused by our treatment, especially by the older treatment that we have done in the past. And a PET-CT would pick up that as well. And we unfortunately also have experience with patients who had a PET negative for myeloma, positive for a second cancer. The good thing is the patient had no symptoms yet, so we could treat the second cancer very early, which then led to a good prognosis for the second cancer. So that's another kind of tweak where I can convince insurance companies to pay for those imaging.
Mm-hmm. Okay, great. Okay, well, I'm going to take a little commercial break here and show the Myeloma Crowd Community Forums. So as everyone knows, we have created this tool called HealthTree. We keep adding different features to it over time. You can track your disease with it. You can find your genetic twin in it. What I'll be showing you today is the Myeloma Forums. But we also have HealthTree University that both Dr. Landgren and Dr. Hillengass have participated in. And we are so happy that they did that. You can accelerate myeloma research, and here is where you can join Dr. Hillengass's study. You can see your treatment options. You can find a specialist and a coach. You can find clinical trials you're eligible to join, and you can find reports of all the data that we're gathering. And to date, we have about 7,600 myeloma patients registered in the tool. So if you go to Myeloma Forums, these are our Myeloma Crowd Community Forums. And what we like about social media is that, we can gather with people that that have myeloma. So this is great. But sometimes on social media, things get lost in an eternal feed. And it's really tough to find what you're looking for when you're looking for it. So sometimes you might post something on Facebook or whatnot, and then, a day later, you can't find it. So these are forums. We have a set of initial topics. We just barely launched this. So we encourage you to suggest topics. You can suggest a discussion topic. And then for each discussion topic, we have subtopics. Or discussion questions. And as you can see over here, if you go back, this is a thread of all the new current discussions that are happening. So you'll see kind of on every topic, you'll see the topics are different down here. You can say if it's helpful or not. You can share that on social media. You can reply to someone's comment, and then that will show up as a reply. And if you're in a topic like smoldering myeloma and you don't see a question that really addresses what you want to consider, these are all monitored and moderated. So we want to make sure the question goes into the right location. You can suggest a discussion question here, and then we will consider adding it in the right place or wherever it goes. And then people can, you can just chat. In the future, you'll be able to connect individually. So if you click here, you can go straight to that particular discussion topic. And in the future, you'll be able to chat, direct message people in the platform who are there.